lung ultrasound is not really our expertise, but it's always a great honor. And the challenge is increasing because we have more and more to say, but we must stay in the timing, so we will not lose 1 second. When we have 30 minutes, we will stop, and that's all what we can do. So some doctors think that Lichtenstein is lung ultrasound, that I just added lung to the critical ultrasound. We humbly revendicate to have, in 1985, it was the night, to take ultrasound clandestine from the radiologist's hands to the physician's hands by stealing the machine in the night because I needed to see what had my patient. And in 1989, I had the privilege to work with François Jardin, the father of echocardiography in the ICU. There was echo on site, and it was the best place for defining critical ultrasound. And I was very happy to make what you call today a revolution much before the laptop technology that had no utility. We had a perfectly portable machine in 1982. And of course, in critical ultrasound, there is also lung ultrasound. If you don't make the most important, you don't make a completely holistic job, and lung is maybe the cherry on the cake. So just rapidly how it happened, and not what you read in the articles of North American literatures. Here is a short case scenario that I see in my nights. I am a medical intensivist, so when they call me in the night, it is half of the case for a critical setting. This is an example of an acute respiratory failure, and we will see how the B profile will be useful. That is an example of the blue protocol. In 30 minutes, I will have no time to describe the clinical setting, just to tell you they are not sufficient for making a clear diagnosis, and the X-ray does not help me really. Is it bronchial or cardiac asthma, mainly? I would like to relieve this lady. So you could make the traditional approach, that is echocardiography with all the stuff, Doppler, on E prime, etc., etc., etc. But here, this lady has precisely no good window. The heart is hidden by this bloody lung, and this is what we see instead of a beautiful parasternal view. But most of you, if you practice lung ultrasound, will have recognized the familiar lung rockets and the familiar lung sliding, that is the B profile of the blue protocol. In spite of this poorly informative tool, we have a standardized test, lung rockets, lung sliding, that is, in the words of the blue protocol, the B profile, and the priority diagnosis is hemodynamic pulmonary edema. So we can immediately, without the light, it would be better, we can rapidly relieve the poor lady who had eventually pulmonary edema. That is fine, the light is good, thank you. The usefulness of the A prime profile in the Sesame protocol that we saw this morning, maybe with the same people, cardiac arrest. A younger lady, we are completely blind to treat the most critical setting. So very rapidly, I take this machine that is small, 32 centimeters. I can go in the narrow places easily, switch on 7 seconds. This machine is 1992, but it is the fastest of the world. And only one probe, which is universal, so I don't have to think, which probe shall you take? With the panic that you can imagine. Universal probe, no button to touch in the Sesame, as was proven this morning. Well, let us do it. Sesame protocol begins by the lung. There is a place for the heart, but at the end. And we see immediately top that the left lung is at the chest wall, no pneumothorax, and that the right lung, whoa, is not moving at all. There's the video, you can see some movements, but completely standstill pleural line. This is the typical A prime profile of the blue protocol, and I know why this poor younger lady has made a cardiac arrest. You put a chest tube and Next patient. Well, the use of the A profile in the false protocol for an acute circulatory failure. So here we have to update upstairs. A young man who took too much doses of drugs, including carbamates, and you can see he has signs of circulatory failure. Well, we activate the false protocol, and we see that the carbamates do not explain the shock. There is a good left heart function, but mainly no tamponade, no dilatation of the right ventricle. We make lung ultrasound. This poor young man has lung sliding with this A line, that is the A profile that we all have in this room, A profile, and we will just consider that he is false responder, and we will give to this patient fluids. And we just treated a hidden hypovolemia. I don't insist. So lung ultrasound helps to make hemodynamic assessment. False protocol. We are on time. Good. So the experts of imaging said that is fog, that are parasites. And we said, no, it's a language that we just need to decipher. We used this antique machine from 1982, but we have exactly the same signatures today. Nothing has changed. So in 30 minutes, a bit of how, a lot of why. In the SURF, our modest training center, we make a holistic approach to critical ultrasound, and not only we include the lung, but we also make it the most critical target. That's normal. This is the main vital organ, so it's not very strange. And what we can say is that all the manufacturers who have developed ultrasound without consideration of the first vital organ have made targets, machines, probes, settings, curricula, where maybe everything is, I'm a bit sorry to say that, completely wrong. If you do not consider the most important. That's fully logical. So I think we have a lot of progress to do with the applications, the curricula, and the machines. So we are based on 7 principles, all turning around simplicity. The first principle, a simple technique is perfectly suitable. So I did not bring the machine, but you will see the images, and this is our vision since decades. The more the unit is simple, the more lung ultrasound will be simple. The machines of today make it very confusing, very difficult. And we have to find extreme emergency solutions for that. So this is one probe for the whole body. We will come back again. The knobology of lung ultrasound is no knobology, no filter, no setting. We are always in the CSAMI protocol setting for cardiac arrest, and this is the setting that we use for inserting a subclavian line, for checking if the bladder is empty. So we make it very, very simple with old or nowadays machines. Principle 2, lung is a place where air and water are together. So that's very simple. It follows gravity. I did not invent it. So you will see pneumothorax upstairs near the sky, not anterior. Anterior only if the patient is supine. And the pleural effusions downstairs. The lung is the widest area, principle number 3, so we have to define areas of interest, and in the blue protocol, we have used the blue points, which are 2 anterior points and 1 as posterior as possible point for making blue protocol. 3 points, not more. Advice of the SURF. This figure, forget it. If you put your probe on zone 2 or 4 of the International Consensus Conference, you will never see the lung. Make your experience. Principle number 4, everything arises from the pleural line. This is the pleural line very rapidly, where is the interface chest wall lung. It looks a bit like a bat, so we called it the bat sign. Why not? The bat is an old user of ultrasound. She knows much better than us plenty of things regarding the technology, and I could speak hours, but time is running. Lung ultrasound is based upon artifacts, principle number 5. And artifacts is not a dirty word. It is art, which is noble, and facts. An artifact is a fact. B lines exist. Well, it provides critical information. And in the Merlin space, that is this space limited by the pleural line, shadow of ribs, and bottom of screen, we will define in the normal lungs these horizontal lines that are repetitions of the pleural line. Very briefly, so they were called the A lines, first letter of the alphabet. Principle 6, lung ultrasound is dynamic because it's a vital organ, so it moves all the time. And you see in the Merlin space, when I put the video, that you have a sparkling of the whole of the Merlin space, which means, by the definition, that it begins exactly from the pleural line, not 1 millimeter above, not 1 millimeter below. This is the definition of lung sliding. When you make the M mode, with an intelligent machine that puts the two images not only side by side, but exactly side by side, you have easy access to the seashore sign showing the dynamic of the Merlin space. Here, clearly, we have a lung sliding, waves, sand, separated exactly at the pleural line. And there is no need for Doppler when we have these kind of machines. We use zero filter in lung ultrasound. I ask you to choose your image. There is a filter in one of the two images. If you don't know, if you try to resuscitate a patient with that image quality, you will be lost. You will ask for a CAT scan. With that, you know, oh, lung sliding, without any confusion. There is no space for confusion in lung ultrasound. No space. So one remarkable point, with only two signs, the A lines and the lung sliding, you define the normality wherever the probe is applied. That is providence, and A profile when it is anterior. So the learning curve will have nothing to do with the traditional other fields, especially echocardiography. The seventh principle, the acute disorders touch the wall. That's another providence. That is all cases of pneumothorax, pleural effusion, interstitial syndrome, and most cases of lung consolidations. And you don't need to see the whole to make urgent therapies. So the signatures, all assessed with CAT scan, in our website, surf.net for the details. Pleural effusion. Since we are very late, we will go rapidly. The fluids are not anechoic. They can be white, gray, what you want. So forget the word fluid effusion is anechoic. Only anechoic fluid collection is anechoic, but we are professionals. So we will use another sign, that the color, which is the quad sign that shows the lung line, which is this brilliant white line that indicates that this patient has a very trace but visible, 100% visible, let's say 97% visible pleural effusion. Also, it moves like a piston, so we will have a sinusoid pattern of the lung line. It's very simple. We are obliged to go rapidly, alveolar syndrome or lung consolidation, and we will try to do that in one slide. I hope I will succeed. We have one sign for the non-translobar lung consolidations, which is the fractal sign. That is, you see a structural image, and after you see artifacts white artifacts, randomly done, it makes a fractal pattern. You see immediately, oh, it's not a effusion, it's a consolidation. When you have a translobar consolidation, here underlined because there is some fluid around, you can see for once, will it work? You can see the shape of the lung for once. That is an anatomic vision of the lung, which is completely not normal, which means that the lung is completely occupied by some fluid, I don't know which fluid, but occupied with fluid, translobar, it is the lung sign. Specificity, quite 100, good. So we will not speak of the pathophysiology, the term that I see so often in the literature, the subpleural consolidation. It makes no sense at all. Please save your word count. Do not use the word subpleural. And we will not speak of the air bronchograms that can be dynamic or not. We will not speak of the lung pulse that indicates that the lung is at the wall, but the lung does not work because it should be 6 hours. Interstitial syndrome. So it's not at all a hostile word. The manufacturers want to suppress the artifacts that would kill lung ultrasound. The elementary sign is the B line. That is, we have a SURF definition, which is a bit complex. We have 7 criteria. But once you have them, you have a universal definition that works all the time and with no space for confusion. I thank Bill Gates, by the way, who allows me to make beautiful slides where words are missing. He is very rich with a very poor tool, like his General Electric, for instance. Well, the B line is always a commit tail artifact, which always arises from the pleural line. You see the red here, which always moves with lung sliding. And I would add, when there is a lung sliding. And 4 criteria are almost always, and it allows you to make a universal definition. Almost always it is laser-like, you see like this laser rays. Almost always it is long, that is not fading. Almost always it erases the A lines that should be located exactly at these locations. Almost always the B line is hyperechoic, that is white like the pleural line. And you have a definition that works all the time. The developed signs of interstitial syndrome is lung rockets. Lung rockets means more than 2 B lines between 2 ribs. That is not more complicated. From 3, that is not, but from 3 B lines, you have interstitial syndrome. Nothing is more simple than that. Alveolar interstitial syndrome is not at all our definition, because this is alveolar, this is interstitial. So we are obliged to make some housekeeping work. Let's forget. Pneumothorax, we will try in 2 slides. The first slide, so the image will not be very beautiful. I'm sorry, somebody should push the button and it will be like this. Thank you, Bill Gates, thank you. So you have A lines and you have no lung sliding at all, making the stratosphere sign on M mode. It is completely sensitive and not at all specific. It is the first step. Once you have the A prime profile, which is anterior because you begin anteriorly, you make 1 step and you search for the lung point. Once you have this lung point, that is this sudden apparition of an activity that replaces the A prime profile, you have your diagnosis with complete confidence. for the same cost that is nothing, it indicates the volume of the pneumothorax. I must be very fast. I'm sorry. Blue protocol. So blue protocol is a fast protocol, I'm sorry. It can be done in far less than 3 minutes sometimes, which indicates, which considers the lung, no comment, the veins when you have the A profile, and not the heart. To simplify, we have no time to explain why. We use a machine that allows us to be rapidly on site. We use a probe that allowed us to write all our books. Thank you, Bill Gates. And this is the probe of the intensivist. Maybe not today, but you will see in 30 years, it will be the probe that we will scan the whole body. The decision tree of the blue protocol. I'm sorry to be a bit fast. The main disease that we saw in most of our adult patients seen in the merge admitted to the ICU. We will see a bit of this data. How can we reach this data, this accuracy, and mainly by combining two signs and giving a location. For instance, this patient, it should move normally. Thank you. It moves. Normally, what do we see? We see, enfin, we know that we are the anterior wall, and we see the pleural line, we see lung sliding, we see A lines. This is the A profile. That is lung sliding present, no lung rockets, A profile. All the videos are at surf.net, not in your mobile, but in your computers. I'm sorry. When you will see a patient with massive pulmonary embolism, this is the profile that you will likely find. You will make your experience at home, you will see. I think the battery are a bit tired on this remote for the next speaker. When you see lung sliding but with lung rockets, you call it the B profile. The word B profile indicates lung sliding. And wait your next patient with a hemodynamic pulmonary edema. This patient will very likely have the B profile. Here we have the same lung rockets, but no lung sliding, completely double pathology. When you will have this profile, you will see that your patient is quite always victim of pneumonia and or ARDS. ARDS is severe pneumonia, usually. We simplify. So we will not speak of the pathophysiologic basis, time is running. And of course, when we see no lung sliding, no lung rockets, that is the A prime profile, we will, of course, highly suggest a pneumothorax. So again, what is the B profile? It's the B line, which is multiple, that is lung rockets, that are anterior symmetrical, that are associated with lung sliding. This is the B profile. And here only you can say sensitivity 97, specificity 95, not 100. There are differential diagnoses. If someone has a batteries, because I have no time to take my remote, it's not very pleasant. Lung sliding present, multiple B lines moving, diagnosis of pulmonary edema, hemodynamic, with this accuracy. 20 seconds for the diagnosis. That's a fast protocol. 20 years for having the microphone. If there are young researchers, please be ready to wait 2 decades or more. Blue protocols not only ruled in hemodynamic pulmonary edema, but it also ruled out pneumothorax, lung sliding, lung rockets. It cannot be a pneumothorax. It also ruled out, usually, nobody has a battery, a COPD or asthma, And pulmonary embolism is infrequent with the B profile. It's 4% of cases. Thank you. In pulmonary embolism, there is, sorry, it's full? Okay. So, no, let's not lose time if it is full. Time is running. I have only 30 minutes. I'm sorry. But it does not work well. Well, I will use the few seconds that remain for saying that in pulmonary embolism, we will look not the heart, but the lung also. And this is the normal profile, that is the A profile. You make your experience. On the anterior chest wall, of course. Lung sliding present, A profile. Here is time for looking at the veins. In a special protocol, when you have a thrombosed vein, you are specific 99% of cases. This is why we don't develop the heart in the blue protocol. We do it after. So for the venous part, we make unusual approaches that you will practice in 50 years because they work better than the traditional approaches. Pneumonia in one slide, because we will speak of that, I think, yes, tomorrow. 4 profiles. We saw the B prime profile that provide 90% sensitivity and 94 specificity that are found in most cases of IRDS, which is completely logical. Lung consolidation is not pneumonia. Please beware. You can see that in plenty of disease. Questions. Why is the heart not included? Because we see the suffering organ, so it is logical that we scan the suffering organ. What do we do in practice? We see the heart after the lung, after having made a diagnosis. We have some time, we look at the heart. Said differently, here we see a patient who is dyspneic, but if you want to know about the systolic or the diastolic left ventricle function of the coaptation of the valves, look well, no B line, no hemodynamic pulmonary edema. The left heart works correctly in this patient. That is holistic ultrasound. So I will stop at 30, so this is not a mandatory slide. Is blue an acronym? So, no, the patient is blue. And is it important? No. In 1 minute, I will just give a few words on the potential of the false protocol, that is the use of lung ultrasound for hemodynamic purpose. And this is the decision tree that shows that we begin to scan the very pericardium and then the heart and then the lung for obstructive shock, that is pneumothorax, and then the lung for ruling out cardiogenic shock, and then the lung for ruling out hypovolemic shock when your fluid therapy improves the patient. If the fluid therapy does not improve your patient, the A lines will become B lines, and you have made a diagnosis of septic shock. Distributive, that is in daily practice, septic shock. And no measurement is done in the false protocol, just visual medicine, just images. 30 minutes, so I had plenty of things that too late. No problem. I call Paul Elbers, I think, is the second speaker. While the slides are prepared, I can answer to a few questions. Ultrasound in cardiac arrest, it was done this morning. Pink protocol for IRDS. Come on, Paul, I am finished.